for the possibility to share my experience on folitropin delta stimulation protocols based on patient's type. The schedule of my lecture consists of 3 introductory words and stimulation in 3 groups: poor responders, normal, and high. Serum AMH and ultrasound AFC have shown that provide a direct and accurate measurement of ovarian follicle pool. These markers have generally shown a similar capacity to predict ovarian response. I'd like to present the large multicenter study reliability of AMH and FSA. Both markers, we know that both markers are comparable and decrease with age. But concerning the patient with several successive cycles, for AMH seem much better than for AFC. The next publication, this last year, individualized gonadotrophin dose selection using markers of ovarian reserve for women undergoing in vitro fertilization, they slightly favor AMH and AFC. But the result is that dosage regimen given according to certain ovarian reserve did not alter the number of women achieving the targeted number of oocytes. The first group is very difficult, is the poor responders. According to recommendation, GnRH antagonists and GnRH agonists are equally recommended for these poor responders. Clomiphene citrate alone or in combination with gonadotrophins and gonadotrophin stimulation alone is equally recommended. A gonadotrophin dose higher than 300 units is not recommended for this group. My case study come on group 4. The first case study, the patient with 35 years old, normal BMI, her menstrual cycle is very short, 23-25 days, infertility 4 years. Several years ago, she was performed laparoscopy and removal cysts from both ovaries. Here is hormonal analysis and emphasize the AMH extremely low, 0.3 nanogram per ml, and AFC below 5. This picture, this is the IVF protocol, and I start folitropin delta, 12 micrograms of day 2 for 9 days. I retrieve 4 COC, all of this fertilized, and I obtained 2 good blastocysts, and one of this, the fresh transfer was occur. The second group is most common, is normal responders. According to recommendation, the GnRH antagonist protocol is recommended for this group. The addition of letrozole to gonadotrophin is not recommended, and reduced gonadotrophin dose is probably not recommended. This is the second my case study, 29 years old with obesity, menstrual cycle is regular, worsening factor male, previous treatment is 3 times of EUE. Here is hormonal analysis and normal AMH level 3.5 nanogram per ml. This picture is a protocol again. It is again first IVF cycle, start typical of 2 days of menstruation, folitropin delta 12 microgram is according to recommendation the increase by 2 due to obesity. The trigger was ACG. I retrieved 10 COC, fertilized 9 oocytes, and I obtained 4 blastocysts. She was performed fresh transfer. This is very challenging group, these high responders. And the GnRH antagonist protocol is recommended for women with polycystic ovary syndrome. And the addition of clomiphene citrate or letrozole to gonadotrophins in stimulation protocols probably not recommended. GnRH agonist protocols are used. Some reason a reduced gonadotrophin dose is probably recommended, and GnRH agonist trigger is recommended for final oocyte maturation, and the freeze-all strategy is recommended to fully eliminate the risk of late onset OAGSS. The pay attention of the IMH cutoff for PCOS almost 7 nanogram per ml, for non-PCOS almost 5 nanogram per ml. We know that folitropin delta reduces risk of OAGSS, and individualized dosing with folitropin delta notably reduce moderate severe OAGS versus conventional dosing with folitropin alpha. And analysis per AMH quartile demonstrated that these statistically significant differences are driven mainly by patients with the highest pretreatment AMH level. This is above 3.5 nanogram per ml. This is the last year publication, and individualized evaluation stimulation with folitropin delta improved both life birth rate and safety outcomes among women with elevated AMH level, and estimate decrease early OAGSS. The third case study, the patient 33 years old, normal BMI, normal menstrual cycle, infertility 4 years, and no polycystic ovary syndrome, only polycystic ovary morphology. This is hormonal analysis. Testosterone is normal, and AMH slightly elevated, 7.8 nanogram per ml, and typical picture of polycystic ovary. This slide is the, again, protocol of IVF. This is the first protocol of this woman. We start folitropin delta 8 microgram for 11 days. And the trigger was a GnRH agonist. I retrieved 12 COC, fertilized 6 oocyte according to Polish law, and I obtained 4 blastocysts, and 5 oocytes were frozen in this patient. No OAGSS. The third study, this is polycystic ovary syndrome from phenotype A. She's 30 years old, normal BMI, and secondary amenorrhea, the menstruation only after progestin. The very interesting is history, the previous fertility treatment, time trying to conceive in this patient is 4 years. Previous treatment is stimulation of ovulation 4 cycle of clomiphene citrate. After the 1 cycle of gonadotrophins alpha in doses 75 to 100 for 12 days. After this, she developed OAGSS, like mild or medium OAGSS. After that, the break of treatment, depression, and 1 year ago, she was performed laparoscopy and electrocauterization of the ovaries. This is a hormonal analysis of this patient, elevated LH, slightly elevated of testosterone, but this is one year after surgery, and extremely high of AMH, 22 nanogram per ml. This protocol starts without the menstruation with doses of folitropin delta 6 for 10 days, and I retrieved 18 COC. Of course, the trigger is a GnRH agonist, and 3 fertilized 6 oocyte because this is according to Polish law. It's only 6. And I obtained 3 good blastocysts, and all of them is freezing. The last case study is polycystic ovary again, is normal weight, oligomenorrhea, amenorrhea, but a short time on infertility, only 1 year. This is the hormonal analysis of this patient, slightly elevated testosterone 0.6, AMH 12 nanogram per ml, and polycystic morphology in ultrasound. This is the schedule of the treatment without the menstruation, only USG before and pregnancy test before starting. And folitropin delta 3 microgram, 12 doses. The first 6 is every 2 days, and after that, in ultrasound, no dominant follicle. They change the fashion in the every day, the next 6 doses, and after that, we obtain 1 dominant follicle, 20 millimeter. To summarize, I pay attention for folitropin delta is good for stimulation in women for low, normal, and high ovarian reserve. Is highly recommended for women with high risk of OHUSS, like PCOS, or elevated AMH above 3.5 nanogram per ml. Very good tolerance of the medicament, and highly useful for stimulation of monoovulation in PCOS patients. Thank you.
Thank you so much. I guess much room for questions or discussion. Anybody who would care at this age? Okay, let me, one question. The last patient you demonstrated, you started with hormone injections every other day.
Yes.
What is the rationale for that?
I started every day for every 2 days.
Yeah,
every 2 days. The idea for the small stimulation in the I afraid of the hyperstimulation every day.
But is it different from a daily low dose?
The 3 microgram, the low. Sometimes the doses in the very elevated AMH is 2.3. The very, very small doses.
Okay. Thank you so much. Then